Good afternoon, colleague, and welcome to today's session. And to facilitate the session, I'll be doing that for today. I'm Dr. Khozya Zyambo, and we're privileged today to have Dr. Sivile talk about advanced HIV treatment centers and cascading down the treatment and care for those that need advanced treatment care. So we are very happy to have you join us today one more time. I think we had a bit of the interruption in services that came along with the freeze in aid, but we do believe that we still have to provide services as been guided by the Minister of Health, and we had a session last week just to highlight how we're going to do that, and so we believe that we have to continue and move forward. And so this afternoon, we want to invite you all to participate actively, get involved and engage. Use the chat box to share what your questions and your concerns. And you can also raise your hand. We'll be able to see it, and then you can make your comment and unmute. Please keep your microphone muted at all times. And if you can you can also keep your video on, or you can turn it off. That's okay with us. So thank you very much, everybody, for joining us. We will just start our session, and I will allow Dr. Sivile to pick it up from here. Thank you.
Good afternoon, colleagues. Good afternoon, network. Again, it's my pleasure to come to the ECHO network to discuss advanced HIV treatment centers, centers of excellence, and HIV drug-resistant treatment in Zambia. So the objectives of the discussions today, we'll look at the definition for advanced treatment centers, the definition for HIV centers of excellence. We'll give the functions, what these advanced treatment centers are supposed to be doing from the program's perspectives, give the requirements for setting up an ATC, requirements for referring a patient to an ATC. We'll talk about the services that are offered, and we'll introduce HIV drug-resistant testing and the results used in our program. So we'll start with a poll. The technical team, are you able to launch the poll? You can do all the three. We advise the network to poll. I can't see any polling. Okay.
So which of the following is an indication for referral to an advanced HIV treatment center? A, HIV diagnosis challenges with persistent discontent results, extensive side effects, intolerance of multiple first-line ARVs, first-line treatment failure with documented HIV drug resistance on results, D, second-line treatment failure. Which one of the following is an indication for referral to advanced treatment centers? Please go ahead and poll. We have a few seconds that we're going to do that. So we have a total of 231 individuals that have connected. So we are expecting 230, close to that, people participating. So far, we only have 136. Okay, I think we'll end the poll. and move on to the next poll question. Very interesting question. Okay. Let me just show you what people managed to see. Okay, move on to the next question.
So, Dr. Zyambo, this is a terrible question. Actually, it was supposed to say which one is not. But
Okay.
nonetheless, people have answered it. I'm happy. We'll discuss. Yes.
All right. So we have poll question number 2. SS, a non-alcohol misuser, is on TLD and has been on EAC for 3 months. His repeat viral load is 500,000 copies and is still non-adherent to ART. What is the correct next course of action? A, continue EAC and repeat viral load in 3 months. B, do a genotype and continue his current therapy. C, do genotype and switch to AZT3TC and DRVR. D, refer him to psychiatric services but continue his current ART. Another very good question. Things that we're always meeting in our practice. And I can see people are polling. Most people think that D is correct. Others think that A is correct. Please do make your poll. Only have a few more seconds before we end the poll. Okay, thank you very much. We'll end the poll here. And those are the results. You can see most people thought D was correct, then followed by A. I'll stop sharing and move on to the final poll question. Oh, we only have 2.
There should be a third one.
So we have this next one here. SS is on tenofovir, lamivudine, and dolutegravir. His recent, sorry, let me just reshare this one. Okay, great. So SS is on tenofovir, lamivudine, and dolutegravir. His recent genotype shows extensive resistance to DTG, TDF, and lamivudine. Which ARVs should be switched to? Is it TDF, 3TC, darunavir? Or B, it should be switched to AZT3TC and DRVR? C, it should be switched to ABC3TC, DRVR. Which one is correct? Thank you very much, everybody, for participating. At least more than half have participated. So we can move on to the next slide. Dr. Sivile, you can pick it up.
Thank you, Dr. Zyambo, and interesting results from our network. So these are just the poll questions. So as a way of introduction, advanced treatment centers are centers of excellence where complicated HIV care, treatment and support services are given. And these will include third-line antiretroviral therapy, which is also called salvage therapy, where they're offered to people with HIV and those who have complex needs. So centers of excellences are in our case, they are a regional hub that are offering comprehensive package of HIV services. These may or may not have third-line ART. So all regional tertiary hospitals are supposed to be as centers of excellence. So we expect facilities like Choma, Kasamas, General Hospital and the like to be centers of excellences, but they may not be ATCs. Also to note the differences between advanced treatment center and advanced HIV disease. So these are different. So this is a center. Advanced HIV disease is simply those individuals whose CD4 count are below 200 or indeed who could have an AIDS-defining illness, or that is a stage 3 or stage 4 condition. Now, the functions for ATCs are mainly to provide care to patients who have complicated HIV course for whatever reason. And also, we want to use them for HIV drug resistance surveillance and for research purposes. So when we are introducing, for instance, new molecules and so on, we like starting from these ATCs and with other centers. Yeah. And also, there should be hubs for the provision of training and mentorship to healthcare workers in the management of HIV. So as you know, we are going through decentralization process. We expect that these regional hubs or ATCs should provide that. Of course, the main ATC that we have is UTH has been for a long time been providing this mentorship and training for all facilities in the country. So we do have these 7 approved, should I say, ATCs in the country: University Teaching Hospital, Adult and Children's Hospitals. Livingstone Teaching Hospital, this has performed well over a long period of time. Ndola Teaching Hospital does perform well, it goes down, performs well, and so on, but we do monitor. Arthur Davison Children's Hospital, obviously attached to Ndola Teaching Hospital, we do have our excellent leads there, like Dr. Sam Miti, Dr. Paul, and the like in Ndola. Kitwe Teaching Hospital, we did open this. There's been some challenge to keeping up the service. So it does kind of goes downwards, then comes back online. But the last few years, we've even been having a lot of exchange programs with Kitwe Teaching Hospital. Lewanik Central Hospital as well, Chipata Central Hospital. Apologies, I did leave out Levy. Is also our ATC. They provide a third-line care. We have Dr. Kapolowe there, Dr. Ngwira there, and other individuals. So application for those facilities which are supposed to be ATCs, you can apply. I think we've received some application via your SMSs or your PhDs to the National HIV Program through the PS, addressed to Professor Mlenga, or myself. Then you should meet the requirements in terms of equipment and human resource, as I'm going to mention. Then you should have technical support by UTH Central Team. We do visit these ATCs to just mentor and to see that things are happening as prescribed. We recommend that there should be some attachments, that some of the staff from there, they do visit ACOE or PCOE for a period of 2 weeks normally, so that they just see how you are supposed to run these ATCs, because sometimes they are delicate. And annual visits by the national team to the facilities, they are recommended. Previously, we used to do that religiously. The last few years, we do combine with other activities. So We do have a guideline. This is a bit odd. This is called an operational guideline for advanced treatment centers, approved by the Ministry of Health. You can find it on the net. If you want a soft copy, hard copy, we can share if you are interested. This just shows you how these third line services are supposed to be provided. So these are the functions. We expect specialized HIV care, HIV research in HIV drug resistance, especially the surveillance part, what's happening, regional hubs for mentorship and training, and other research. So on the middle of that is that you are supposed to provide those are the functions of advanced treatment centers that we have. So these are the minimum requirements for setting up an ATC. You need a clinician who's specialized in infectious diseases, or physician or pediatrician with experience in treating HIV experienced patients, or any other person who's demonstrated that experience, but it has to be an MD who judge and see how much they've learned. Maybe others who have training in, a certificate in HIV management and so on, and MSc, infectious diseases, that sort of thing. Yeah. So we do approve that these individuals should be able to provide these services. We need a pharmacist because the drugs needs to be monitored well. Sometimes there's different types of combinations. Yeah. Lab is critical. This is key in providing guidance on quality sample collections and referral. So you need an established lab and a biomedical scientist there. You need nurses, trained in HIV nurse practitioners, and who are able to demonstrate leadership in setting up these centers. Support staff for data, and critically, you need counselors as well at the facility who are qualified to provide these services. So these ATCs, obviously, they're supposed to be on a housed at a tertiary center, which is supposed to be centers of excellence. Then you can upgrade the center of excellence into an ATC. So you can find this in our guidelines for advanced HIV disease. I think all these are well tabulated if you have the guideline. Yeah, so for the lab requirements, viral load testing capacity is critical in this place because it just helps to monitor patients better. Resistant testing, you need to be able to separate and process samples in readiness for transportation. For resistance testing, as you know, we only have 4 labs right now in the country providing HIV drug resistance: the Charles Lab, Arthur Davison, UTH, the so-called Kaposi Sarcoma Lab, and the UTH Virology Lab. You need to be able to have full chemistry panels, liver function test, LFTs, create urea and creatinine and electrolytes. Those hematology panels, the CBAs or the full blood count, that's a requirement. You need to be able to store these samples appropriately in your freezers. Yeah, so those capacities for separation and storage should be available. Pharmacy, you need the drugs to be available, third-line drugs. Right now, we are talking about the Darunavir 600, which is separate, not the combined Darunavir ritonavir. The Darunavir 600, etravirine as well. Those are now strict third-line drugs, but we'll discuss where DTG comes in and what other drugs we want to bring on the fore. You need to have a secure medical record system, including a backup. That is smart care, is a requirement. Sorry, my slides are delaying. Okay. So when an individual comes with complicated HIV, this is the assessment that must be done. Commonly, these individuals will have a second-line treatment failure, and evaluation we should include the following. Adherence to therapy is critical. Before you decide to send these individuals to ATCs, we need to know a comprehensive adherence stories. What are the gaps? What are the barriers? What's been going on? And if those have been addressed. Pretty much in most of the situations, the story starts and ends with the adherence assessment. Obviously, full drug history is required. You need to tell us when you are referring what drugs this individual has taken, when they started ART, and so on. Any drug-drug interactions in the past that you expect, or drug-food interactions. For instance, this could be an individual who was on atazanava and maybe they were on antacids, that sort of thing. Drug tolerability, have they had challenges with side effects? The viral load and CD4 count story over time, the trends needs to be documented when referring or assessing this individual. And history of HIV drug-resistant tests, those are available. Those are required for you to make a comprehensive assessment. So sometimes I do get a lot of requests for or consultations for HIV drug resistance. People just send a report, you know, on WhatsApp, a picture of this is a lab and what drug should we give. This is not sufficient. We need the comprehensive history for the decision to be made. Yeah, just like when you are referring an individual. So indications for referral to an ATC. So this is an individual who's failing first-line treatment. They shouldn't be managed at any other center apart from an ATC. Those who are intolerant to all drugs in the first line, or it's a complex intolerance to the drugs, also to second-line therapy. Complications of PI or INSTI-based regimen, maybe extensive weight gain, renal failure, that sort of thing. Those individuals who are receiving complex regimens, so regimens that have been, maybe they are coming from out of the country and so on, the regimens are not in the usual regimens that we have. They should be seen at or referred to ATCs. We prefer that adolescents and young adults who started ART in infancy and have been transitioned to adult care, the treatment should be done at ATC as well. Reason being, their history of treatment should have been started a long time ago. They would have been on other drugs, sensitized to different types of drugs, and the story should be clear. Those who have renal disease, cardiovascular disease, for instance, an individual with extensive bone disease should be seen probably at an ATC. It's reasonable to say we are referring this individual to ATC. Severe or life-threatening adverse reactions, individuals should be sent to ATCs as well. And like I've said, those who are coming from other countries and they were receiving some therapies that we may not have in this country. We've had such situations. Yeah. So prerequisites, I've mentioned to these already. Adherence, current regimen should be documented and the history of regimen. The person who's sending it and certified to prescribe second-line therapy. Baseline investigations, order of genotypes, if they're available, the results, to be nice. And you need to make sure that an appointment is made in advance at that ATC before by directly contacting the specialists where feasible or the focal point person in the province. So the commonest reasons why individuals should be seen by at the ATC second line treatment failure, we all know the definition is similar to that of first line treatment failure. That is a high viral load at 2 consecutive times. We prefer that before someone is sent to the ATC, a genotype is done, HIV drug resistance. And as you know, HIV drug resistance, we have 2 types. You have the genotypic or phenotypic testing. Genotypic testing is where you directly test specific mutations in the genes of the viral isolates that are associated with HIV drug antiretroviral resistance. Phenotype is where you see the ability of the virus to grow in the various concentration of different ARVs drugs. So this is different. Genotypic testing is preferred. That's what we use. Phenotypic testing is usually done in research settings. And we advise that HIV drug-resistant genotypic testing is not done unless that individual is taking ARVs consistently. So in those individuals who are not taking ART or ARVs should not have a genotype done. So in our country, we do genotype testing for 3 reasons. The first one, just for surveillance. Second is for clinical management. And also we do routine surveillance through the cadre. Surveys, we do them periodically, typically after 4 years. We were due for one last year, so we'll see if we can do one either this year or next year. Yeah, but it was last done in 2019. So HIV drug-resistant testing and results, its results use is a gateway for third-line treatment. We don't accept anyone being put on third line without having an HIV drug-resistant test. And you can use it for first line. Typically, this is to monitor surveillance for INSTI resistance, but also for patient use if you are not sure. Results should always be done with consultation with an ATC. So we will want to put in a routine mechanism where we can audit all HIV drug resistance results and how they are used using an echo platform. You will hear soon we'll have an HIV DR echo where provinces will be presenting all the results that they've had in that period, and we discuss how to manage them and what decisions should be done over the HIV drug resistance results. We are happy that right now, even the DISA is able to give back the results. All of you can attest with me that we've actually improved in the return of results for HIV drug-resistant testing. Going forward, we want to see that the result use also does improve. So the results will give you resistance mutations. So these mutations are just changes in amino acid sequence from what used to be there. This is the base in the wild type. And this may change susceptibility to a drug or how the drug will bind on that active site. You have major mutations and minor or accessory. Then you do have polymorphisms. Polymorphisms are changes in the gene or mutations that are not occurring on that site that will impact susceptibility to ARVs. So this is just an example where you have aspartate changing to glutamate as an amino acid that is being changed. You can see there, it's the first G, the guanine, which is changing to adenosine. So G to A, you can see that. Yeah. So this is a point mutation. You can have an insertion. This is where you have an amino acid codon being put into the gene altogether, and it will give that serine amino acid. So this is an insertion. All these will impact if they happen at the site in that peptide of an enzyme where the drug acts at the site that has to do with the binding of the drug, that will impact on the susceptibility of that particular virion to that particular drug. And the nomenclature will say changing from M at position X to an amino acid this. So here, this is a common mutation that happens. Okay, someone has taken over the sharing of my screen. Khozya Zyambo and the team. Yeah, so you have lamivudine or amitriptyline will change that reverse transcriptase enzyme peptide at position 184. It will change from methionine amino acid to making a valine amino acid. So we call that M184V. So that change will make the amitriptyline or indeed lamivudine not to bind at that active site because the conformation of the enzyme does change. So when collecting samples, care should be taken, and here we've improved. We've talked a lot about just how to collect these advanced HIV drug resistant samples. So all samples should be sent as plasma, and cold chain should be maintained during transfer. Usually we used to prefer that liquid nitrogen is used, but now I think folks in the lab do have dry ice that they can use, not a normal ice. Yeah. And this is the referral system. You can UTH, ATC, or labs, and so on, and you can see how the patient should move. So communication is key. Right now, all facilities should have a directory. You know who to contact at AIDC or any other HIV center, ATC center, and even lower centers. We have a national directory which all of us have access to. So samples should move from that facility to the molecular lab, and then that is taken to the HIV drug resistance lab. Example is at UTH, but you can have alternative to the provinces that are within the catchment of Arthur Davison lab. They'll send there, and the results from the lab will go to an ATC, and that ATC will communicate back with the facility, and the results will go back to the facility, and there should be that interaction. And we prefer that at the end, the patient is transferred to the ATC, shown by that blue line. So this is just going in depth of how much how you deal with the sample. Remember, the storage should be at -20. And the lab team, I think we've done a lot of training. So genotype has got limitations. The first one, it's costly. That's why we can't have labs everywhere. For now, the decision has always been to have it centralized with those labs that we have. If there's the variants of viruses that are resistant are little in the prevalence in that sample. They are below 20%. You might not pick them. That's why you want ARVs to wipe out the wild type, so that you have chances of the proportion of the virions who are which are a variant from the wild type. They should be at least above 20%. You do have other methods that can pick everything, but normally this is what is recommended. So at least 4 weeks of taking ARVs, then you can do that test. So absence of resistance should never be interpreted as that particular individual is susceptible to treatment. Prior treatment history is very important. You can have what is called archiving of these mutations. So just because the HIV drug-resistant test has come out susceptible might not really mean that that individual is actually susceptible. So if the history, the viral load, and so on needs to be taken into consideration. And of course, how compliant that person has been. Yeah. So we do have different mutations, and I'll skip this, which can give different impact. I'll skip this slide. So when someone comes to this third line center or ATC, we will select which drugs they should use, and we base that on the history and the HIV drug resistance results. And clinicians initiating patients on third line outside ATCs, sometimes there is some challenges to transfer the individual and so on and so forth. We can do that over the phone with consultations. Yeah. So this is a short guide, just a synopsis of the options that we have. So you do have different groups or phenotypes of individuals. So the first group will be those individuals that have failed second line, and they do have drug-resistant mutations to PI-based regimen from your results, but they've never taken DTG before. They are not sensitized to DTG, and they have drug resistance mutation to NRTIs and also NNRTIs like efavirenz. So these individuals, the options that we have, you can still give them DTG because they were never sensitized to it. There should be fewer now in our setting who should have been on group 1 who belongs to group 1 because a lot of people have been sensitized to DTG already now. Yeah, but you do give the twice BD darunava ritonava because it does work in a lot of individuals, even with prior PI mutations. We do add the travairine, and we do continue with the backbone of tenofovir 3TC or AZT, whichever is available. For those who failed second line with a PI-based regimen, and they've taken DTG before, they are sensitized, or they have a genotype which shows drug resistance mutation to DTG. And obviously, they have drug resistant mutation to NRTIs and NNRTIs like efavirenz in this case. The option is to give darunava ritonava twice a day. You add etravirine. You can have tenofovir, lamivudine. In some cases, plus or minus, you can still continue DTG with a double dose depending on how the drug resistant mutation for DTG they are used. They look like. There are some mutations where you can actually double the dose for DTG. If the patient has failed second line DTG with drug resistance mutation to it, but has never received PIs. There are individuals who started on a tripla, went to DTG and something else, then they've never gotten a PI. Still, we've taken off lopinavir or atazanavir from our program. As you all know, the choice will be here. The combined darunavir, ritonavir, that's 450 tablets, and you give once a day, 800 a day. You add the travairine again. You can add tenofovir ritonavir as a backbone. Some people will feel that a travairine might not be sufficient, might not be important in this case, but we still do that because these individuals are highly experienced. So, like I've said, we use the HIV drug resistance testing for surveillance. All of us now know that we do have HIV drug resistance to DTG in the country. These are some of the example of cases and what we've been seeing. These RR263K is very common in most of our individuals, giving that intermediate, but we do see a lot of high level mutations to DTG as well, especially recently. You even see it in very young children, like a 51-year-old month, a 50-year-old 11. There was 22-month-old female on top there, a child just getting DTG for a few, and they have that resistance. So with that kind of mutation, one of the options we did was to double that dose for that child, and the child is still alive, but still has compliance problems. So when you do get a result, we do get a lot of calls over these results. Please bear in mind or take into consideration the treatment history. This is critical for interpreting genotype results. You can't do it without knowing what drugs the patient has taken before and the history. Most of the time, we do presume that if they've taken these drugs, then they are resistant, even if the mutations are not being shown, especially common mutations like M184V. If you don't see it, doesn't mean it's not there. Yeah, it should be the first mutation that would occur. Yeah, so you cannot be excited that it's not there and someone has been failing. Yeah, and you do see other mutations. Yeah, exactly. Mutations do have an influence on each other through what is called hypersensitizations or cross mutations. Certain mutations will cause certain drugs to work even better. For instance, a K65R, which is given by tenofovir, would cause some of the thymidine analog mutations to work even better, like there will be hypersensitization and the like. Then you do have cross mutations, mutations which are caused by cabotegravir, like for instance, Cabere will have an impact on dolutegravir, that sort of thing. Yeah. Yeah. And for that reason, a discussion with an expert or a panel is usually very, very helpful so that you look at the case holistic. So those who fail first line, we still want to emphasize whatever mutations they have and so on. Now you see this is our second line, which is darunavir based if they were on DTG based mutation. I mean, regimens. A reminder on DTG, on darunavir and the anti-TB treatment. So rifampicin can be used with dolutegravir. You can increase the dose, give the DTG twice a day. Lopinavir, you have to double it, increase. Darunavir, the reduction in the Cmax is over 95%, and there's no need of even increasing it. So you avoid, just like atazanavir, you avoid. And now, because of this, we are using darunavir most in second line, and a lot of our cohorts, they are on TB treatment. In second line, we have rifabutin in the country. It's available, at least where I practice at UTH, we have rifabutin. So ZAMSA has, we encourage all of us to get this molecule before it expires. Yeah, we have rifabutin. Now, the backbone, still we want to mention a little bit about whether you can recycle. This is critical because even last week there was a WHO guideline review meeting, and we will not preempt, but it looks like the outcome will be that we should get rid of AZT in the future. Yeah, so we'll see when we revise the guidelines, but I wanted to quickly just show the evidence, how it is. Yeah, so we do have quite a number of trials which we've shared on this platform. The first is the Nadia, where they have people who are failing from Truvada, a tripler with efavirenz based, and they were put either on DTG or darunavir, and we can see that the finding from these results is that individuals, those who were given TDF, even if they were coming from a tripler, did better than those who received AZT, both in the DTG or darunavir arm, even in the presence of pre-existing mutations. Yeah, and darunavir had no mutations at treatment phase. Yeah, so this shows that you can reuse your TDF, even if somebody failed to eat. The other one was what you call 2DS study. This was done in Kenya around 2020. And again, those adults who are on second line PI plus NNRTIs were switched either to DTG or they continue the PI. They did very well on DTG and NNRTIs, and the NNRTI of choice was used there. So even those who had reused NNRTIs did better. The third one is the Vicent, which we did at UTH in Lusaka. We presented these results. at AIDS 2024 in Munich last year. You can see down there, I think I did the presentation on behalf of the country. So we presented 144 weeks, and these are some of the results that WHO is now using to see. We showed that those who got DTG with either TDF or tenofovir did better than those who did get lopinavir or atazanavir in terms of viral suppression. Yeah. The last slide is a DFT. Similarly, they got individuals who are failing first line, and they were switched either to darunavir, ritonavir dual therapy, or darunavir and a TDF backbone, or DTG and TDF backbone, or AZT backbone. And they did still well, even if you recycled, as long as it was TDF, DTG or darunavir as well. Interestingly, in this study, one of the things that was shown is those who got darunavir had lesser weight gain compared to those who got DTG. So yeah. So our recommendation is still the AZT, but this is a recommendation, like I've said, that might change. We'll look at the stock, probably it's just to wipe out the AZT. We think recycling can be done where pill burden, toxicity, and tolerability are more important, which should apply to a number of individuals. Clinical judgment with expert opinion must be obtained where unclear and on a case-by-case basis. So we welcome these cases speak to us so that we can discuss them. So to end my presentation, I wanted to show this case as a discussion. We would like to hear your thoughts. So here we have a pediatric patient from St. Paul's Hospital in Challenge. So one day I was doing actually my technical support visit. Actually, I was in Mansa and I got this interesting. I was in Mansa, were doing some global fund work, and I got this text with these drug-resistant results from St. Paul's. So they do get results. I think that was about October, and I wanted us to discuss these results on the call. I don't know, Mr. Moderator, if I'll be allowed.
So we can take, I don't, anyway, let's do the case first.
And
then we can have some questions.
Yeah. So, and I did this because there was no case, and I felt this was a topic that we need an example. So this is what we'll be doing when we have that HIV drug resistance echo, where we pick the results and the story and sit down, debate, discuss to look at how best to handle this particular case. So we have a pediatric individual who was born, date of birth is in 2011. He should be a 14-year-old now. Last year it was 13 years old. Started DRT in 2012, meaning that they were congenital HIV. So now they were on TDF, XTC, and DTG, and this I got it from DISA. You can see how nicely the results come when you do the correct thing, like our individuals, our colleagues from St. Paul's. So previously, they were on ABC3TC and DTG, and last viral load was done. This result was was collected in July, and that's the last time also the viral load was done. ESC was completed, so we have all this data in DISA. Reason for HIV drug resistant test. So this is first line drug resistant failure. Yeah, so they were still on first line. It's HIV treatment first line, and the other things is just whether it's a repeat or the ART number and so on. And have they done EAC? This is post EAC? Previous viral load was done for routine monitoring. So the last viral load was 230,000. And now the current regimen they were on was TAFED, obviously because they were 13 years old. Yeah. So the results. So for the results, what would like you to do is to, before you look at whether it's high level resistance and so on, I've seen results where people just send, oh, a back of high level resistance. Tenofovir, no, we are not interested in that. We are interested in the mutations themselves. So you go to those NRTI mutations. You can see there's an M41L, a V75M, F77, M184V, L510W, and T215Y. So this is a bit strange for this individual to start having a thymidine analog, a 215. We do see it sometimes. Other drugs can confer, but you can see there are common ones like the M184V over there. NRTI resistant mutations, they had 2. The common one is a K103N. This is from efavirenz. And then you can see what resistant type they do have. You can see that the history says they've never been on zidovudine. One would wonder, yeah, and you can see that there is high level zidovudine because of that T215Y and M41L that they have. They don't have a K65R, so you can see that the DTG, the TDF is intermediate. For etravirine, we do a score. So here they just have pretty one mutations. The score will be very low. So you can see that potential low level, but otherwise the rest will be on the high side. Similarly for something like rupivirine. Now, protease inhibitors. If I go to the next. So there was one PI mutation, a 54V. This begs the question, do you think the drug history was correct that was presented to us? You find that probably there will be questions in this case.
Does it mean in your results we are more interested in mutation?
Yes, the question was, we are interested in the mutation than the results. So the way these results are given, the mutations is what the lab gives. It gives you the mutation. Then these results, what is high-level resistance? It's an interpretation using a database, what is called a Stanford database. There are also other databases. There's a European database where it's fed in. So it's not as important. It's an interpretation of other people. In other words, for example, it's like an AI. There's an AI which has a lot of information behind, and they tells you this means this. But that's not what the result from the machine gives you. What the machine gives you are simply the mutations, and the story should start from there. Now, you can see that there's a PI mutation in this individual. But the history says this individual has never been on a PI. So this is how we'll handle this case in a third line. We'll probably not believe the history and we'll believe the results. I have seen some suggestions there. Yeah, but if you look at our program, this individual started DRT on 2012, and they are saying the previous results, the previous drugs they were on was ABC3TC and DTG, but we all know that we started giving DTG even to children recently, like Dr. Zyambo, 2020, somewhere there even. So you can see that the history is incomplete. In such a case, this individual, if they truly started treatment, started DRT in 2012, they should have taken a PI alluvia in the past. So it is missed. So that's how, when you get the history, even if there are some drugs that are missing, you have to finish the story. Yeah. So you will not rush in this case to say, okay, atazanavir or alluvia is low level, let me give it. You will just be compounding mutations. If you look at that as an example. Yeah. So the history, that's why it has to be discussed. You make a reasonable decision out of it. But from this result, you can agree with me that there's no way this child didn't take a PI in the past. The lab result shows that, and the history suggests that they should have taken the lab result a PI if they started treatment on in the past. So we'll continue.
Sorry, Dr. Sivile. I just want to say that so some experts have joined in. Please, you can go to the chat box and you can be responding to some of the questions in the chat box as Dr. Sivile is running through the case. Thank you. Go ahead.
Thank you, Dr. Zyambo. Yeah. So, and we thank St. Paul's for sending this question, this test. So you can see that there is some PI, low-level resistance. If they took this PI a long time ago, there could have been some archiving of the mutations as well in this case. So I think this is one of the cases where the results just showed that there was a high level resistance to dolutegravir, but the mutations were not given from the lab. And I've seen several other results from the lab like that, where others, even NRTI mutations, are not given. It's just a Stanford database result. That is incorrect from the lab as a practice. We want to see the numbers, the mutations themselves, because they give us critical information. So anyway, they did report that it was insti resistance and very high level. So we do not know what those mutations looked like. So these are the gaps. I brought this case so that we see where the challenges are in our results use. And you can see that the viral load was 200. Previous viral load was 197. That shouldn't be close to 200. Shouldn't be that different. Should be within the range, the confidence interval. Yeah. So I have questions for discussion as the last thing. What other details are required to make an assessment or to make a conclusion, and what is the advised regimen of choice in this case? in this 13 or 14-year-old. I don't know if the experts on the call or before the experts come in would like other members of the network to offer their comments. Thank you very much.
So thank you very much, Dr. Sivile. I think that was a marathon of a presentation. Now we want you to invite for any clarification, questions, comments that have come through. I know some questions in the chat are speaking to the case that we've been discussing, but just to clarify some of the things that you've seen in the presentation, please raise your hand, then we'll allow you to ask your questions and unmute. So, any questions? So we do have experts like Dr. Matibula. If there are any additions you have, please.
There's a hand from Jackson Mwewa, Dr. Zyambo.
Oh yeah, so
USAID Action.
see you. Please go ahead and unmute and ask your question.
Thank you so much, Dr. Sivile. That was a very profound presentation and very insightful. Maybe just a comment before a question. Since we are dealing with the advanced HIV disease, I think what was missing also, it was also important to know what has been the CD4 profile for this child who is an adolescent. Yes, as well as the social economic history of the parents, and just to see what the social impact that is surrounding the child. Then for the try on the regimen, I think we can still use the Dlanavadea and the 3TC as well as Tafed. But I also wanted to find out how many kg was the client. But however, the Dlanava TDF 3TC can be used for this person, for this our client, because I can't see any resistance for Dlanava as well. Yeah, then that's it. And then coming to the question, Dr. Sivile, I see on your presentation indicated you looking at the costs attached to DR resistance, and you when you look at this these USAID freeze, what's the plan? Because I think you used to another thing that was supported is courier system, and I saw that actually DR testing is no longer be in the package of service delivered to our IPs. Or what are the plans to ensure that the continuity of care for DR testing also maintained? I submit share.
Thank you very much. We were on mute, sorry, for the comments and your question. I'll answer the systems issue. So for the CDC supported provinces, we know that they are back supporting the whole package of care, including everything. And that's what we expect. We had a meeting as a program with the USAID last week, and we did ask that question, what about HIV drug resistance? They said they'll get back to us on that one, but tentatively they are looking at it as a life-saving service as well. So we'll hear a categorical answer, but tentatively it looks like it should be allowed to courier. You know that courier on its own is allowed even for the US. It's part of the waiver, even for the USAID regions. So I'm not worried about HIV drug resistance service as at now when we are using the waiver. Going forward, it's another story. We will advise as we review the package and see how things unfold. Yeah, but for your suggestion of what medicine, what regimen can be put on, I would like some other experts to come in what they think, but I don't know if there's anyone else who's got a suggestion, would want this to be a discussion.
Dr. Sombo on the call, Dr. Chanda, Chitalu, Dr. Matibula. I don't know if you're still on the call, please do make your comments if you've been following. Okay, maybe, I don't know, maybe they've dropped.
Yeah, so I do agree with you that history about the status of this child, things to do with as adherence, support, and that sort of things are critical, even when before we decide and start talking about which drugs to give her or to give this particular child. So those are critical. But we would like to hear what others think would be important as other details that we need to manage this child better.
Okay, so I'm seeing here some comments that those are very difficult questions, Dr. Sivile. Maybe the treatment history for the mother is very important. Then the other comment, can there be need to recheck the viral load and CD4 after the child had been put on Tafet? What could be some of the factors that could lead to having drug resistance to all drugs in certain classes, e.g. integrase inhibitors? These are said to have high resistant barrier, and if looking exposed to integrase inhibitors, most clients were just introduced to it in a few past years. Other drugs have never been introduced to the recipient of care, yet still show resistance. Perfect example is a CAB. And so there was just another question to say, if DTG resistance, integrase is resistance, does it affect other integrase inhibitors as well? I think somewhere on that.
Okay. I'm talking too much. I don't know if there are other experts, Dr. Zyambo. You are putting it.
I was looking out for some, but I can't find some.
Those are difficult questions for me as well. All right. Yes. So the issue of why is a child showing resistance to all the drugs, even those that they've never taken? So this is what we call cross resistance. You can, if you are resistant to DTG, depending on the numbers, that's why we follow those numbers. You will get resistance to the whole class in most of the time, even to cabotegravir, to bictegravir, and the like. Similarly, if you are resistant to cabotegravir, you will get resistance as well, cross resistance in that class, even to dolutegravir as well. That's why those individuals we are putting on Kabele, we need to be careful that they don't seroconvert. And when we are starting them on therapy, we choose usually a DTG sparing therapy. If someone was on cabotegravir or they've taken cabotegravir injection before and they do become positive, when you're starting first line ART, you don't start DTG based. You have to start something else. Yeah, so you do have that cross resistance. Yeah. That's why the history is important, consultation is important, and that discussion is important as well.
So, and I think just to clarify that there should be a distinction in treating advanced HIV disease and treating a clinically difficult case, as in this case, where you have got resistance that has developed. So in an advanced HIV disease, you're looking at somebody who has immunological failure and has now developed disease as a result of their immunoincompetence. But when it comes to treatment of drug resistance, you're looking at the failure of the current regimen that the child is particularly taking, and the mutations that have actually affected those drugs. And that can be seen from the results that are produced from the results. Yeah.
Dr. Zyambo, I want to make a comment on, there's a comment that maybe we should repeat the vial load after we've given Tafed.
Yes.
So in this story, this individual was on TLD, and now you've given Tafed. And the resistant pattern shows that even Tafed will not work in this case. And what we avoid doing is prolonging someone on therapy that is failing for a long time. So there is no need to say, when the results show that drugs don't work, you don't prolong those drugs. Because you worsen the occurrence of mutations, and the virus become more, we have a combination of mutation. Yeah. So for instance, someone who has dolutegravir resistance, if they have one mutation, if they continue on taking dolutegravir, they will develop more mutations to dolutegravir, especially if their adherence is bad. Yeah. And the first results, there was a series from Malawi, which actually they found that's one of the reasons why you have very bad DTG resistance around, like you've seen it would be in these cases, because you would think that this person, they continued on ESC, perpetual ESC, which we discouraged from one of the questions we give. Once you know that someone, after ESC, someone is not adherent, you do not continue the ESC. There's nothing like, extended ESC, as people say in facility. We don't have such a recommendation from the program. If ESC after 3 months, somebody is still unsuppressed, actions needs to be taken. It means whatever package you gave for your ESC failed. You either refer to a psychiatrist, or you can refer to an ATC at that point. That is our recommendation. We don't want someone on ESC for 6 months. Dr. Zyambo's pediatric program is actually the culprit in there. I've seen children on ESC for 2 years, Dr. Zyambo, in facility. We don't want that. Yeah, so you change. In some countries, ESC is just for a month. We expect it to work if you've done it properly. There are some hands, Dr. Zyambo.
Yes, is this Azadi? You can unmute, and then after that, then we'll have further stuff. Thank you.
Okay. Thank you so much, Dr. Zyambo, and thank you so much, Dr. Sivile. Dr. Kazadi, I don't know if you still remember me. We met a couple of times at Ndola Teaching Hospital.
Definitely, Dr. Azadi, you are my brother. I know you very well.
Yeah, thank you so much. So I would like, first of all, to appreciate your approach, Dr. Sivile, to just highlight the importance of the history on this patient. I believe looking at the drug mutation, probably this individual, this patient should have been on AZT, TTC, and a PI, and was later on switched to TLD, and then now the patient is on TAF-ED. And I would like to make an attempt to actually switch this patient to a regimen that could assist this patient. Since the resistance mutations shows that there is intermediate resistance to TDF or TAF-ED, I will still want to use that one. And the TRTC or emtricitabine, the M184V is there. But as we know, that mutation is quite beneficial for us. So for this patient, I will still use TDF TRTC as a backbone. And I will do an attempt here to double the dose of DTG. That would be one possibility. So I'll use TDF, PTC, and double the dose of DTG. That is one possibility. And the other possibility, I can still use the same backbone, TDF, 3TC, and use PIs to be specific high dose darunava and ansritonava. So basically, that's how I would attempt to treat this patient. Thank you.
Thank you, Dr. Kazadi. It's nice to hear from physicians who are actually taking care of these patients. Dr. Kazadi is the one in the ATC at Tindola, our anchor with Dr. Mwale. I can see Featherstone. My brother, how are you? We haven't greeted each other this year. Happy New Year.
Same to you. Thank you so much.
No,
Yeah.
thank you for that.
Yeah, so I just wanted to just comment on the courier, HIV drug resistance courier. So I think as a part of sustainability, just to mention to the network that as we were rolling out Kabele, we did build capacity in all the provinces so far, aside Wapula and Northern, in terms of them riding on Zampost courier, because we saw that that is what was sustainable and very cheap. And all the provinces, aside those two provinces, have the equipment in terms of the taking ice, in terms of the courier, the cooler boxes, the hardcore cooler boxes. And we have even given, we did supply the temperature loggers. So capacity is built within all the other provinces. All what is required is, as you indicated, whenever there's any sample that needs to be sent to UTH, they need to communicate, or indeed Arthur Davison, they need to communicate. And then Zampost has also been trained in these provinces. Zampost is able to pick those samples, and they maintain the temperatures, and the turnaround time for us to receive the samples in Lusaka, for example, has been on average within 24 hours, the sample is in Panji's lab. So just to encourage the team that let's utilize Zampost, it's cheaper, and I think is more sustainable. Over.
Thank you. Thank you. These are our partners who are helping us. We appreciate. Yeah, we've done quite a number of samples with the Featherstone and the team. Yeah, I can see Mpanji responding to some of the questions. So for the sake of time, colleagues, let me wind up with this dissertation.
Report?
Yeah, before I report, let me just comment on the case. So indeed, what we recommended on this case is to give TDF. This was a 14-year-old. We assume the weight was okay. So TDF, 3TC, and darunava, ritonava, this is a combined one, which is 450, but giving it 2 tablets, 800, 100. Reason being, there was very minor mutations to it. For the PI, darunava we feel could still work, and we are sensitive to the adherence challenges that this individual would get. Obviously, alternatively, if you know the individual, you can still give the twice a day darunava to give a chance, but the understanding that it will still work. Yeah, in this case. Yeah. A comment on doubling the dose of DTG is not a recommendation that we give in individuals who have resistance as a program, unless in peculiar circumstances and there are just certain mutations that you'd want to do that. So if instis are not working, let's go to darunava, which we have and works very well in our setting, and we have a lot of it. So let's avoid the doubling of the doses. In most times, we might just be wasting, prolonging the time someone is getting immunosuppressed and that sort of thing. Yeah. Yeah, that is our recommendation in a case like this. So imagine this is an individual who should still go back to once a day treatment, knowing that you have to be sensitive to adherence, and we want to make our experience as good as possible. So they'll take this drug either in the morning or in the evening, whichever is okay for them, before sleeping or just waking up, whichever after supper, once a day, whatever time that would be. The Truvada or the TETL, whichever is available, plus darunava, ritonava combined. This would be the choice regimen for such an individual. Yeah, so but cases would differ from case to case, and opinions would differ, and that's why we prefer these cases are actually discussed. Dr. Zyambo, we can go back to the poll.
Okay. So this is the first poll. We say, which of the following is an indication for referral to advanced treatment center? Would you like a quick comment?
So this was supposed to say which one is not an indication. Yeah. So you can see that a quick comment will not let people do the polling here, but when you have diagnostic challenges, you can send the individual, especially if you are not sure whether they have HIV or not. When there's extensive side effects or intolerance to any multiple first-line ARVs and second, send that individual so that we evaluate at ATC. First-line treatment failure with documented HIV drug resistance on result, this is not a reason. You take to second line of failure sequentially. Yeah, so C was the answer if the question read not an indication. Over second line treatment failure, these are typical cases for third line or ATCs. We can go to the second poll.
Okay. So this one is SS, a non-alcoholic misuser, alcohol misuser, and is on TLD. Has been on EAC for 3 months. His repeat viral load is 500,000 copies, and is still non-adherent to ARV. What is the correct next course of action? Yes.
So Dr. Zyambo here, as we are seeing the polling, we are happy that D seems to be the answer. Yeah, so you continue that, but refer for psychiatric services because this person has got alcohol issues, so that they sort out the problem. We discourage switching therapy when adherence issues have not been sorted out. Yeah, so it looks like you failed to sort out the alcohol misuse challenge that this individual have. And we have CETA. Now we have our national psychiatric primary care package that we use to make these services available. Obviously, there are a lot of things that can be done to help the individual. Thank you, Dr. Zyambo. The answer is D here.
Okay, the final one, again, SS on tenofovir, lamivudine, and dolutegravir. His recent genotype shows extensive resistance to DTG, TDF, and lamivudine. What ARVs should be switched to? I think we've discussed this quite a bit.
Yes, we did.
So here there's a suggestion most are going for B. You can respond.
Yes, Dr. Zyambo. So this is one of those cases where people have to hear us correctly. So even though the guideline says B, in a few patients, you would want to give A, because recycling in most cases could be helpful. Yeah. So either B or A, they are both correct with regards to separate different individuals. We'll give very strong guidance on this as before the end of the year, where likely the guidance will be, the answer will be A, but we have to wait for evidence and manage the thing. So do consider A and recycle as well, because I've showed the evidence that it shows this could be helpful.
All right, thank you very much. I think we'll have to call it a day now. Most of the time that we had has run out. And so we'll just listen to some final comments and thoughts from you, Dr. Sivile.
Sure, Dr. Zyambo. Yeah, so in conclusion, I think they've taken my slides down, but a few things that I would say. Firstly, we want to decentralize HIV drug resistance tests and also ATC services. We want them to be accessible throughout the country, and people shouldn't travel a long time to have these services. Yeah, so we want facilities to upgrade themselves to ATCs, especially provincial centers. We know where these services are not available as of yet. Secondly, recycling can be a choice in certain circumstances. Thirdly, it's an issue of not prolonging individuals on ESC. We need to switch them early. So the take-home message for all of us in provinces where we are, especially those provinces that don't have ATCs, Northwestern, Wapula, Mchinga, Northern, and the like, let's think of how we can. We've given you the list, what is required. Apply to us, speak to us. Let's start working in that direction so that we can help our people. Thank you for having me, Dr. Zyambo.
Thank you very much, Dr. Sivile. Very interesting session and really mind-opening in improving our care. So I think so many requests have been made for the slides. Just know that if you have access to the iEcho platform, you will be able to see the slides on that. Otherwise, they will be shared widely on different platforms, on the WhatsApp platforms, and those that receive, please share with others. Thank you very much for joining us and for your participation. We'll see you next week for another important session. Goodbye.